Hello, everybody. I'd like to introduce myself. My name is Zaineh Khalil. I am a nurse practitioner here at the UCSF Minimally Invasive Gynecological Surgery Department. Thank you, everyone who has joined or has already watched our webinar, even from last week. I'm happy to welcome you all tonight. This is the second in our series of the ENACT Core B webinars. This is all part of the UCSF-Stanford Endometriosis Center for Discovery, Innovation, Training, and Community Engagement. And this center is focused on understanding endometriosis mechanisms, improving disease classifications, discovering new treatments, enhancing patient outcomes, training future researchers, and engaging the community to support research and empower those impacted by these conditions. On tonight's webinar, I know for a fact we have one of our wonderful program planners, Dr. Yannet Anaya. Dr. Lager is the section chief for minimally invasive gynecological surgery and the associate director of the Endometriosis Center. I'm not sure she's joined with us yet, but she might jump on a little bit later today. We have Dr. Jessica Opoku-Anane, who is the gynecology chief at Rutgers University. In tonight's series, we'll be taking a deeper dive into understanding the fertility puzzle and how endometriosis endometriosis and adenomyosis may impact pregnancy, and how your endo and fertility specialists will help you towards pregnancy success. Some housekeeping, if we may, before we get started. We love to see all your bright faces, so feel free to turn your videos on if you'd like. However, we just ask that you keep yourselves muted. We certainly welcome your questions and we'll be taking them at the end of today's presentations. So please do feel free to put them in the chat or in the question and answer, and we'll do our best to kind of review them, compile them, and get them answered at the end of tonight's presentations. So we will actually go ahead and pretty much jump right in. I'll start with introducing our speakers. We have Dr. Linda Giudice and Dr. Yannet Anaya. Dr. Yannet Anaya is the associate clinical professor and a reproductive endocrinologist at the UCSF Center for Reproductive Health. And we also have Dr. Linda Giudice, who is a distinguished professor of OBGYN and reproductive sciences at the University of California, San Francisco. She is a biochemist and reproductive endocrinologist. I'm
hi,
sorry.
Zaineh. Hi, my name is Aman. Yeah, can you explain a little bit because
about that. Okay, so I believe I was introducing Dr. Giudice. She's a biochemist and reproductive endocrinologist specializing in endometriosis, adenomyosis, ovulatory disorders, and infertility. Her research focuses on multi-omics approaches and function and dysfunction of human endometrium in health and disease. She is co-editor of 7 textbooks on women's health, endocrinology, environmental health, endometrium, and endometriosis, and has received numerous awards acknowledging her contributions to science, medicine, and mentoring. Dr. Giudice is past president of the American Society of Reproductive Medicine, Society for Reproductive Endocrinology and Infertility, World Endometriosis Society, and International Federation of Fertility Societies. She's an elected member of the U.S. National Academy of Medicine. It is so great to see you both tonight, Dr. Giudice and Dr. Anaya. So I'm going to go ahead and hand over the controls to you.
Wonderful. Thank you. It's really nice to be here, and welcome everyone who's on this Zoom. I'm going to start by sharing our slides. And let me get this into presentation mode right here. There we go. Can you all see it?
Yes, we can see it. It's perfect.
Okay, very good. Wonderful. So tonight we're going to talk about the fertility puzzle, understanding endometriosis, adenomyosis, and pregnancy success. And as Zaineh has already introduced all of us, just to Reiterate, this is a part of our webinar series for our ENACT Center. So tonight we're going to talk about endometriosis and adenomyosis, which are sister disorders of the lining of the uterus or the endometrium, but they're not identical. We're going to hope that everyone will understand their impact on fertility and outcomes of various infertility therapies, and to identify risks during pregnancy in women with a history of these disorders. So what is endometriosis? It's a complex hormone-driven disease and that has a lot of inflammation, especially in the pelvis. So over here you see the uterus, and you see the fallopian tubes, the ovaries, the uterine lining, and also the different kinds of endometriosis. Endometriomas of the ovary, deep infiltrating disease, and also superficial disease. And so endometriosis is where endometrial-like tissue exists outside the uterus in a place it doesn't belong, mostly in the pelvis, where it causes inflammation, fibrosis or scarring, pelvic pain and other pain, and infertility and markedly decreased quality of life. It affects about 10% of menstruators and 50% of infertile women. Most of the disease forms in the pelvis because every time one has a menstrual period, some of that blood actually backtracks through the fallopian tube and lands in the pelvis in a place where it shouldn't be, and so it causes inflammation. And there are some other theories as well from stem cells, but it's also notably risk of developing disease is about 50% genetic and 50% environmental. And there are abnormal hormone signaling in the lining of the uterus, and also immune dysfunction in the pelvis as well as in the uterine lining and also in the blood circulation. Now, diagnosis has been and still is by surgery and obtaining the sample of what the surgeon thinks may be endometriosis, submitting it to the pathologist, and having them confirm it or not. And sometimes diagnosis takes a very long time because of this surgical confirmation, but more and more imaging is being used. For treatment, because this is hormone-driven and estrogen-driven mainly, different kinds of hormones are used to decrease estrogen action. There is variable benefit for patients, and this is described in one of our other webinars. And hormones for pain and inhibiting estrogen are not really good for trying to conceive, because if you inhibit the ovary from having a regular cycle, then you need the egg in order to become pregnant. And there's a variety of comorbidities, including fatigue and gastrointestinal symptoms, autoimmunity, inflammatory and metabolic disorders. And in addition to the personal cost to patients, the cost to the healthcare system is about 72 or more billion dollars in the US alone for treatment, diagnosis, fertility therapies, and loss of work. And so you've seen the three types of endometriosis, and the staging systems go from small amounts of disease, but still patients can have significant pain, to large amounts of disease, the higher stage, in addition to scarring. So adenomyosis is different than endometriosis. Endometriosis is where the lining of the uterus is found outside the uterus, but in adenomyosis, the lining is found within the uterus, but in the wrong place. It's in the muscle of the uterus. And here you can see an MRI image of an adenomyosis uterus. This is the disease inside the uterus that makes the uterus very large. It occurs in about 20% of the general population, high co-occurrence with uterine fibroids, and between 30 to 64% endometriosis co-occurrence. So a lot of women who have adeno also have endo and vice versa. The diagnosis here is not by surgery, but rather by MRI or by transvaginal ultrasound. And as of yet, there is no staging system, but groups are working on this. So risk factors include having the first period very early, or menarche less than 10 years old, having estrogen therapies, and also having prior uterine surgery, like a C-section, a D&C, a myomectomy, and pregnancy termination, surgical pregnancy termination. And the reason why we think the surgery on the uterus can result or increase the risk of having adenomyosis is that what it does is it disrupts this area between the muscle and the lining so that some of the lining can move its way into the muscle and then cause an inflammatory reaction in the muscle. The symptoms for adeno are severe period pain, pelvic pain and pressure, heavy menstrual bleeding and abnormal bleeding, and an enlarged globular uterus associated also with the increased risk of infertility, and as we'll talk about tonight, also in some patients, poor pregnancy outcomes. While we don't have a great classification system, there are different types of adenomyosis: diffuse disease, an adenomyoma, and appearance of the adenomyosis in different parts of the muscle of the uterus. The diffuse disease is not associated well with endometriosis and occurs more frequently with heavy menstrual bleeding and prolonged bleeding and more in older patients. Focal disease is associated with deep infiltrating endometriosis and in younger patients and those with a history of endo and with primary infertility. Now, this is what the textbooks say, but the more we learn about adenos is not always quite the case. So we need to keep our antennae up about adenomyosis and trying to get pregnant and staying pregnant. So with regard to infertility, in endometriosis, this is due mainly to pelvic adhesions or scarring so that the fallopian tube may not be able to access the ovary. In addition, pelvic inflammation can increase scarring within the pelvis, and it can also take or impact the eggs within the ovary, and also the lining of the uterus where the embryo implants. So if that's an inflammatory environment, that's not really a great place for an embryo to develop. In adeno, it's a little bit different. There's a lot of extra motility of the muscle, increased uterine fibrosis, not so much on the outside, but on the inside of the uterus, and uterine inflammation. And also resulting, because of this abnormal movement of the muscle, when an embryo enters into the cavity, it can be pushed into different positions, both with adeno as well as patients who have endo. And then tonight, we will talk a little bit more about the endometriosis and adenomyosis associated infertility and what can be done about it, and also a little bit on pregnancy outcomes. So placenta previa, where the placenta is down here instead of usually in the upper half of the uterus. And then placenta accreta, as well as another disorder that we'll talk about. And on adeno, preeclampsia and preterm birth and postpartum bleeding or hemorrhage are associated with that disorder. So I am going to turn this over to Dr. Anaya, who's going to talk about infertility and the guidelines from a professional organization called ESHRE in Europe, and also very common to professional organizations in the US, like the American Society for Reproductive Medicine. So, Yannet.
Thank you so much. So happy to be here this evening with you. And so, as Dr. Giudice mentioned, when we talk about infertility and endometriosis-related infertility, there's some guidelines that we have from the European Society of Human Reproduction and Embryology that publishes evidence-based guidelines that are just best practice to help us manage endometriosis-related infertility. I should probably start by defining infertility, which is defined as unable to conceive after 12 months of actively trying. These are for patients less than 35. Greater than 35, that diagnosis is given after 6 months of actively trying, and that's due to the significant age-related decline in fertility after 35. And so one of the things that I should also mention is that when we know we have a patient with an endometriosis-related infertility, it's also important to assess for other factors that can be involved. And that's because it's not uncommon to have multiple factors that could be part of the infertility that the patient is experiencing. So, for example, a patient can have endometriosis, but also the male partner may have abnormal sperm parameters that could be a part of the issue, which is going to help us figure out what the right next step is as far as treatment. So as far as specifically just looking at endometriosis-related infertility, there are different treatment options that may be dependent primarily on the stage of the endometriosis. One of the things that, and I think we can probably go to the next slide, but one of the things that is important whenever we determine what the right treatment is for these patients is also taking into account, the length of infertility, the age of the patient, the ovarian reserve of the patient, cost are also going to be parts of how we determine the best next step. As far as patients, treatment with medication, based on studies that have been done, we have found that actually ovulation suppression using medications, things like progesterones and GnRH analogs, aromatase inhibitor medications, pre-treatment are not recommended because they have not been shown to enhance fertility. But in regards to other medical treatments, one of the things that we will recommend are doing what we call superovulation with intrauterine insemination for patients specifically with stage 1 to 2 endometriosis. If you look here in this meta-analysis, you can see that the pregnancy rates per cycle for patients with stage 1 to stage 2 endometriosis was about 15%, but much lower for patients that had more severe endometriosis. And I think one thing I will say that these guidelines, when they talk about the diagnosis, the stage, this is going to be a surgical diagnosis. So the way that the stage is determined is going to be by surgery, but also imaging can also tell us about the stage of the endometriosis. And when we have an endometrioma, which is endometriosis cyst in the ovary, that's going to essentially be like a stage 3 endometriosis, depending on the size. But as you can see here, with the pregnancy rates with this type of treatment, patients that have more of the mild endometriosis, the recommended treatment is going to be superovulation, which is giving the patient medication, usually an oral agent like Clomid or clomiphene is the other name, or letrozole, to cause more than one egg being released, and then combining that with intrauterine insemination, which is taking sperm that has been processed and it's depositing that sperm at the top of the small little catheter. Now, for for patients that have more advanced endometriosis, the other type of medical treatment that we would instead offer is actually in vitro fertilization or IVF. And I'll talk a little bit about that in just a moment. As far as like surgical treatment of these patients, we do find that doing surgery for patients that have more mild endometriosis, so stage 1 and 2, will have a benefit and as far as helping with their fertility. And after surgery, patients, depending on what other factors are going on, the next step could be just trying to conceive naturally after surgery, as a lot of that inflammatory environment has been decreased after surgery, versus potentially going to doing the superovulation with intrauterine insemination. And as far as like surgical management for patients with more advanced endometriosis, the expert opinion recommends that actually going to IVF is going to give you the highest chance of success. As you can see here in the and so as you can see here with patients with endometriosis, we do see some, compared to patients without endometriosis, when we compare pregnancy rates in IVF, so this is in vitro fertilization, we do see that there is an association of slightly lower pregnancy rates compared to patients without endometriosis. In this particular narrative review of multiple studies. And then, as you can see down below here, the live birth rate is also slightly lower. However, I will also say that in other studies, we do see that the pregnancy rates, the live birth rates can be pretty comparable in patients with endometriosis compared to patients without endometriosis after IVF. And then the other thing that we'll see is that miscarriage rates are slightly higher in patients with endometriosis compared to patients without endometriosis. So I think that the bottom line that we based on the overall studies that we have is that patients with endometriosis that undergo IVF may have slightly lower pregnancy rates and increase in miscarriage rates compared to patients without endometriosis, but overall, it is still a very good treatment and can successfully overcome the infertility related the endometriosis related infertility. Now, one of the other things to consider is endometriosis, this is endometriosis of the ovary, and how does that impact the ovary and fertility. So whenever you have endometriomas in just on one side, we do see that ovulation may be less common on that ovary. But whenever you stimulate the ovaries, specifically in IVF, you actually see very similar response. We also, looking at the ovarian reserve, we do see that with a single endometrioma, that the egg reserve is not affected. However, when you compare that to patients that have endometriomas on both ovaries, then we do see a potential decrease in ovarian reserve, or AMH, which is a marker of ovarian reserve. It's a blood test. Now, when you specifically look at patients with endometriomas on both ovaries, we will see in IVF less eggs recovered during the egg retrieval, but the pregnancy rates are comparable or unaffected. And then, however, whenever you're looking specifically at patients with large endometriomas, and these are going to be greater than 5 centimeters, 5 to 7 centimeters, we may see that the ovarian reserve may be compromised and a lower AMH. And in IVF, we may also see less mature eggs, but from the eggs that we do recover, the fertilization rate does not seem to be affected, as well as seems to be no major effect on embryo development or pregnancy rates compared to patients that don't have endometriomas. Now, one of the things that patients ask oftentimes is like, should we remove the endometrioma to improve the inflammatory environment? And in general, we tend to recommend against removing the endometrioma. I mean, I think that the studies have been inconclusive in showing that there is an improvement in live birth rate, but in general, we tend to recommend against it. And the reason why is because whenever you remove excision endometrioma, it is unfortunately you're also gonna be removing some healthy tissue as you dissect the endometrioma off the ovary. No matter how much you try to not do that, unfortunately, because of how the endometriosis is stuck to the healthy tissue, there's going to be some negative impact on that healthy tissue, where we do see a decrease in the AMH levels that seems to persist even 18 months after surgery. So for patients that may be removing their endometriomas, doing surgery and are going to remove the endometriomas because of pain, let's say they're doing surgery for pain, then it's not uncommon that the patient may undergo fertility preservation with egg freezing or embryo freezing prior to undergoing their surgery and removing the endometriomas, because there is a concern that their egg reserve may significantly be compromised. And maybe, that also may depend on, what the baseline ovarian reserve is of that patient. Maybe a patient who has a very high egg reserve, or normal to high egg reserve, maybe we're not as concerned. But in the patient who already may have a lower egg reserve, that may be a consideration, is doing fertility preservation beforehand.
So I would like to just comment on this slide, and that is that often patients will ask about BCL6 testing of the lining of the uterus. And we know that BCL6 is an inflammatory marker that's abnormally expressed in the endometrium, the lining of the uterus, during the window of implantation in infertile patients with endometriosis and unexplained infertility. And so the biopsy is taken in a natural cycle, not during a stimulated cycle. And it's timed to the LH surge, so we know when to take the sample in the second half of the cycle. And if the test is positive, that then says there's some inflammation in the uterus, and there's a high correlation also with a diagnosis of endometriosis and unexplained infertility. So how do we get this inflammation down? Well, aromatase and COX-2 are two agents or two features in the lining of the uterus of endometriosis patients that are highly expressed in some patients, not all, and they shouldn't be. They shouldn't be there. But they reflect and contribute to the inflammation in the lining. So the study shows that after 3 months of a GnRH analog, these markers of inflammation go down. And that is what has given rise now to what do we do for patients who have BCL6 in the lining of the uterus, right in the window of implantation? Should we recommend suppressing inflammation using GnRH analogs with progestins or other approaches. So I'm going to give this back to Dr. Anaya. Just wanted to give the background for the role of ovarian suppression potentially before IVF. Yannet.
Sorry. Yeah, so, one of the things that, we, as Dr. Giudice was speaking about, this BCL6 inflammatory marker and the use of a GnRH agonist to potentially suppress or this inflammatory environment to improve outcomes. And so it is something that we may consider using in patients. Now, unfortunately, the RCTs that we have available have not completely shown a benefit, and that's just because the studies that we have currently don't have necessarily adequate controls to really answer that question. And as I mentioned in prior slides, is that in general, GnRH agonists as other hormonal suppression are not recommended for pre-treatment to improve fertility. Now, there may be some patients that have endometriosis that even with the fertility treatments that we have available, specifically IVF, that they may still have, implantation, recurrent implantation failure, or recurrent miscarriages that we are still attributing to the inflammation that is coming from their endometriosis. And so for those patients, we may want to decrease that inflammation with a medication such as the GnRH agonist. And so, some studies, smaller studies, but studies have shown some improvement in pregnancy rates when you use a GnRH agonist before IVF. Now, the use of the studies that we do have, the use of GnRH agonists for about 3 to 6 months prior to IVF has shown an improvement in an increase in pregnancy rates, and it seemed to be more beneficial in patients that had more advanced endometriosis. Now, one of the thoughts about using these medications prior to IVF is, could potentially this GnRH suppression actually be improving the endometrial environment and improving receptivity. And so, that's one of the questions that we don't have completely answered yet, but I think that's definitely one of the things that could be part of why we see a benefit. I mean, one of the cons of using a GnRH agonist prior to IVF is that because of its mechanism, you're suppressing the ovaries. And so the ovarian response when you do IVF is not going to be as robust because the ovaries have been suppressed by the GnRH agonist. And so that is one of the things you have to take into account when you're going to pre-treat a patient before IVF stimulation. So, sometimes what we may do is, do IVF, get the embryos, bank them, and then do the suppression with the GnRH agonist, followed by the embryo transfer. I think that right now, we don't know what the right length of treatment is. Could be anywhere from 2 to 26 weeks. Some of the studies, we often do it for 2 to 3 months. And yeah, you can go to that. Now, as far as treatment for adenomyosis, now this is going to be a little more sometimes difficult to with the studies that we have available, as far as things like pre-treatment for infertility treatment. One of the things for adenomyosis is that something like an NSAID, which is a non-steroidal anti-inflammatory like ibuprofen or birth control pills or progesterone, I think are specifically like birth control pills and progesterone only pills that you are not able to try to get conceived during that time. So as far as pre-treatment, I think it's a little more ambiguous as this is showing as use of a pre-treatment for adenomyosis. There are a good amount of studies with the use of progesterone intrauterine device for suppression prior for about I think it's like 2 to 3 months prior to fertility treatment. I personally have not used this method. I think Giudice has done that for some of her patients. But that is one of the things that has been studied for adenomyosis patients that seems to have some benefit. Other things like the GnRH analogs, those are medication suppression that has been shown to increase pregnancy rates, and as far as other things like GnRH antagonists and aromatase inhibitors, which I think are definitely potential options. There are just not enough studies to know for sure, but I think from a mechanism standpoint, those are actually things that we are starting to use now as a way to treat adenomyosis. In regards to surgical options, the thing about adenomyosis is that it's, because of, if it's, let's say, diffuse into the muscle of the uterus, you can't resect that. And so now you can have something like adenomyosis that's more focal, and in those cases you can try to resect the adenomyosis. But the thing about removing them is that it's a really big surgery. And one of the major concerns after removing the focal adenomyosis is the potential risk of uterine rupture once the patient is pregnant, and if they when they go into so one of the things that I think that we are doing less of is actually doing surgically removing adenomyosis. As far as other things like endometrial ablation, embolization, and high intensity focused ultrasound, I think those are things that we do less of. And definitely especially the endometrial ablation and embolization, they're really, specifically endometrial ablation, they're not really compatible with trying to conceive after, just because of the potential risks. Now, as far as looking at reproductive outcomes after IVF in patients with adenomyosis, we do see, in comparison to patients without adenomyosis, that there is a association with lower pregnancy rates and live birth rates, as well as a increase in miscarriage rates. But I think that overall, IVF can be a very good treatment for patients with adenomyosis. I mean, I think that compared to endometriosis, that inflammation is going to have more of an impact in egg quality, and the tubal function, where IVF can potentially really overcome a lot of those issues. I think that with adenomyosis, it's a little more complicated, but for the most part, we do see overall good outcomes. But the inflammation related to endometriosis of the uterus may be something that sometimes we may have to address. So in this slide, it's looking at the different type of IVF protocols that we may use in patients with adenomyosis. And just really what to know from this slide is that in the studies in the study for patients that used the GnRH agonist suppression for 2 months prior to the ovarian stimulation, those patients had higher pregnancy rates, live birth rates, and lower miscarriage rates compared to the patients that did just a short protocol, which is like the without the suppression of Lupron beforehand. And I think one of the things that we don't know is, what type of adenomyosis, either is it focal or more diffuse that has better outcomes. And it does seem that in patients that it may be more involving the junctional zone, so more diffuse, that may have the lower outcomes compared to focal adenomyosis. And really what this seems to see is a higher rate of miscarriage. So, go ahead. So as far as some of the pregnancy outcomes, the adverse pregnancy outcomes that we may see with endometriosis, the studies that we currently have seem to show that there's no increase of ectopic pregnancy, gestational diabetes, low birth weight or intrauterine growth restriction of the fetus, no association with an increase in operative vaginal delivery or a APGAR score of the fetus of less than 7. There does seem to be a weak to moderate association with gestational high blood pressure, preeclampsia, preterm birth, and this seems to be a stronger association after a natural conception. There also seems to be an association with an increase in risk of postpartum hemorrhage or antepartum hemorrhage. We also see an potential increased risk of C-section, cesarean delivery, stillbirth, admission of the neonate to the NICU, and potentially neonatal death. I think this is probably a lot less, not like a major risk. As far as a moderate association, there seems to be an increased risk of premature rupture of membranes. As you can see from the odds ratio there, seems to be like an increased risk that is almost doubled. And the other thing that we'll see is an increase of placental abruption, which is where the placenta comes off the uterine wall. There is definitely a strong association, and this is, I think, really important, is this risk, higher risk of placenta previa. And when you look at specifically patients with deep infiltrative endometriosis, you can see that the association is almost 12 times higher. And with patients with severe adenomyosis compared to the patients that don't have severe endometriosis, I apologize, you can see that the odds ratio is even higher than that, so much higher association. As far as other things that we see increased are things like placenta accreta. This is when the placenta invades deeply into the muscle of the uterus, and the placenta is not able to come off the wall. And the other thing that we'll see is specifically with severe endometriosis, this increased risk of spontaneous hemoperitoneum in pregnancy, which is like a hemorrhage into the pelvis. All right. As far as adenomyosis and pregnancy adverse outcomes, we do see a very strong association with preeclampsia, preterm birth, postpartum hemorrhage, and small for gestational age. There doesn't seem to be an association with intrauterine fetal demise or a low APGAR score. So I think as far as in summary, for patients with endometriosis-related infertility, in patients with stage 1 and 2 endometriosis, we usually recommend ovarian stimulation with intrauterine insemination or laparoscopic resection of endometriosis, so surgical management. And in patients with more advanced endometriosis, we do recommend IVF. As far as removing endometriosis off the ovary, the concern is the potential decrease in ovarian reserve. And so, in general, we tend to recommend against removing endometriomas for the purpose of fertility treatment. And as far as patients with a positive or elevated BCL6 marker after an endometrial biopsy, those patients, we may consider treating with a GnRH agonist or surgery for 2 to 3 months to suppress the inflammation. I think that overall what we find is that with IVF, we can have overall good pregnancy outcomes in patients with endometriosis. As far as patients with adenomyosis and a history of pregnancy loss, we may, pre-treat patients with a progestin intrauterine device or GnRH agonist plus or minus a aromatase inhibitor for 2 to 3 months prior to trying to conceive or prior to IVF. I think one of the things that we often see is endometriosis coexists with adenomyosis. And so one of the things that is putting together a treatment plan for the patient that can help treat both of these diseases. But before, planning what the right treatment is for the patient, we do have to consider other factors involved.
Thank you so much for a very thorough and comprehensive review regarding endometriosis and adenomyosis. We only have about 10 minutes left, so I am gonna, we've had some questions. I think some of them I was able to answer. One patient, one person in the audience was asking, just as a clarification for one of the bullet points about IUI versus IVF and ovarian suppression, and seem to be just a little needing a little bit of clarification about the recommendation. So is ovulation suppression, let me see if I can.
As far as treatment, yeah, so ovulation suppression is not recommended as a pre-treatment to improve pregnancy rates or for the purpose of improving fertility.
Okay. Can the stage of endometriosis be determined through a transvaginal ultrasound? Dr. Giudice.
If you see an endometrioma, then it's automatically stage 3 if it's 3 centimeters or more. MRI is preferable to discover deep infiltrating disease. And by ultrasound, sometimes you can tell if there's scar tissue just by moving the probe, but it doesn't really give you a stage. So surgical staging will give you the ASRM staging 1 to 4. And then the other way we look at endometriosis is looking at the types of endometriosis, endometrioma and deep infiltrating disease that MRIs can pick up, and sometimes on ultrasound too, but the superficial disease isn't picked up well by either imaging modality.
Thank you. Is the goal of GnRH pretreatment for endometriosis to reduce the size of the endometriosis or just to prevent worsening? And would the recommendation be if the GnRH is unsuccessful after 2 to 3 months, what should you do next, Dr. Anaya?
So I think that we use it in the patient that, let's say, the superovulation with IUI or IVF maybe specifically more for IVF was not successful. This is when we might use the GnRH agonist for suppression prior to IVF again or an embryo transfer. And it's really to decrease that inflammation, especially if there's a concern more of a implantation factor where you have this endometrial receptivity, and this is where the GnRH agonist could potentially help. If that did not, if you do the treatment and the patient is still not able to have successful pregnancy, and of course you rule out other things that could be also part of an issue of a implantation failure or recurrent miscarriages, then potentially surgery. Maybe this patient has more extensive endometriosis that the a GnRH agonist alone, may not have been able to suppress all of that, and maybe they need, surgical management.
Thank you. For Dr. Giudice, do we know what causes inflammation specifically for adenomyosis?
It's thought to be the presence of tissue in a place that it shouldn't be. And when it's sitting there in the muscle, the immune system goes to it and tries to get rid of it, but it doesn't do it very effectively. And so that's what we think the role of inflammation, or at least setting up inflammation. Also, the other thing is that with monthly periods, there may be a portion of the lining that gets more stressed. And this is one of the theories for adenomyosis, and it's called tissue injury and repair. And any repair process usually involves inflammation in trying to get the tissue back to its normal way. So I see another question that may sort of go along with this, and that's if a C-section can cause endo.
Yeah.
That's an interesting question. It doesn't cause it usually in the pelvis, but you can have endometriosis develop, say, in the C-section scar or sometimes in the belly button. And a C-section, some of the lining of the uterus may get dislodged. Usually the body can get rid of it. However, sometimes some of that tissue may go to the place where the incision was made under the skin, and sometimes that's where we find endo, and usually there's a history of some kind of abdominal surgery.
And then I believe there was one question I skipped over on the top. For patients with stage 3 to 4 endometriosis and maybe also an endometrioma on one or both ovaries, does it make sense to do surgical removal after an egg retrieval or IVF and then the embryo transfer after the excision? And then one additional question is how long to wait after the excision of endo before an embryo transfer? I'll kind of let you guys decide who to answer that question.
I think that we normally don't recommend to remove the endometrioma after. I mean, usually would recommend to go, to an embryo transfer because IVF alone has addressed the infertility related to, more advanced disease. Now, could you have a patient that did IVF and still is having implantation failure or early miscarriage? Then in that patient, maybe doing removing doing surgery could be an option. I mean, I think the concern with removing the endometrioma is the decline in the ovarian reserve. And, if the patient's going to have to potentially do, additional IVF cycles, then that can, the decrease in the ovarian reserve can then potentially negatively impact the outcome of the IVF cycle, a subsequent IVF cycle. So I think for the most part, I think in general, we recommend against it, but I think every patient is different, and every patient has kind of like something that maybe the recommendation does not fall with what we normally recommend in regards to the guidelines that we use. I think the other question was about how much after surgery.
How long to wait?
I mean, I tell patients that, 4 weeks to 6 weeks after surgery, they can, do an embryo transfer. As long as they didn't have any complications, as long as they're cleared by their surgeon. I think going, soon into an embryo transfer after they've removed all that inflammation is going to be the best time, the best environment to proceed with a transfer.
And then I can't not ask this question. I know we're running at the end of the session here, but I think this is a great question. What resources are there for community providers, not at UCSF or Stanford, who are working with these endometriosis patients, but and want to assist with the standard of care or what best protocol as they're approaching or counseling their patients about infertility?
I mean, I think that, for patients that have endometriosis and, really trying to figure out what patients need to be referred to see a fertility specialist, and at what point, as opposed, is I think important. I don't know if I'm answering the question.
Dr. Giudice?
I would just add to what Dr. Anaya has said, and that is to go to the ESHRA guidelines. The guidelines are many pages long, but there's a nice short publication. I think it was about a couple of years ago, and they have different algorithms. So that's another way to just, what to do with endometriomas that say that are 7 millimeters or centimeters. But at the end of the day, it may be helpful to collaborate and consult with infertility physicians who and nurse practitioners who have more experience. And I think most people are pretty willing to share.
Mm-hmm. And one thing I wanted to say that I didn't say earlier with the last question is that sometimes surgery is recommended for patients that have pain. I think for the patient that has pain and infertility, that is potentially the right patient to actually do surgery for.
Thank you for that clarification. All right, well, that's actually perfect on time. I'd like to thank you all so much for joining this evening and for your engaging questions. We look forward to seeing you tomorrow night at our last webinar in this series. It'll be same place, same time. We'll be getting into more discussion about the role of research, artificial intelligence, and future innovations for endometriosis. I hope to see you all there. Have a good evening.
Thank you.